we now will be addressing this subject. Guy has given us a gift by giving us this subject, prevention, care, rehabilitation, optimizing the pathway. We saw yesterday that it was so simple to talk about interesting quality and relevance. Well, let's see when we put all this together what we can do with this subject. I would like to first of all understand what is a pathway. And we say parcours in French. There's an administrative definition. But what concretely is the pathway? I would like to ask Sophie BEAUPÈRE to explain to us how do you understand parcours in French or pathway, and especially in the area of cancerology. Yes, so we do have this, we've been using this anterior. We have different driving elements in the different pathways. And then you have the cancer plans, which have enabled us to very early develop a specific area. So we have this real evolution in the cancer therapeutics. We have immunotherapy, which we've heard about recently in the news, but also molecular, biological, molecular, which have more personalized treatments. And prevention, of course, and screening is important. But so that the patients can have access to these therapeutic innovations, they have to be within a pathway which is coordinated at different levels and evaluated. This is very important to be able to propose for in all the territories, regions, these special therapeutic innovations and the cancer plans. In fact, this enables us to, we've been able to structure them very early. As the administration since 2011, we had special pathways for young people, teens, for their different treatments, to see how we can handle their treatments while still being involved in active life. So you have this anteriorness, we have different actors that are really drivers and very enthusiastic. We have actors from all different professional areas. When we work on pathways, you need to have, of course, the different cancer treatments, but also you have to handle the real life of a patient. You have to take into consideration all of this. So very concretely, we develop these pathways for chemotherapy. We are Unicancer is steering, we have within the 51 article, we have this special program with different pharmacists that are a part of this program. And we have 5,000 different patients which had been, and we do hope that we will have a generalized program. But it's not just for the treatment when you talk about pathway, but it's also for prevention, primary prevention, which is more for people that have are at cancer risk. We work on these subjects as well, so that we can really extend our program, which is with the born by interception for those people that have cancer risk. So we work with the French Mutuality, IMA, so we can roll this out throughout the country. So the different actors are very passionate about this. We have a lot of challenges, though, of course. There are 4 major challenges to really evolve the financial system. And this is a real conviction that we have. The financing is more and more with a lump sum. And this enables us to have added value for all the different actors involved and the different roles of the experts, the different people in the city, actors. And so training is important also. How do we handle and train all of these involved in the pathways for therapeutic innovations? Then different digital tools as well, which are the 3rd challenge. How do we roll out the interoperable digital tools, which enable us to have a very smooth pathway? Data, of course, is very useful for research as well and for innovation. And lastly, the 4th challenge, of course, is to have the adherence of the patients. For the, of course, the professionals, but also, of course, the patients to really adhere to their treatment. And we work with different partners, associations. For different associations we work with to define the pathway, and quality assurance, quality assessment is also an important part. And this is done directly by the patients concerning their real quality of life. We should not forget we need the different health aides also, because they also have an important role to play. Thank you very much for this really good, important overview of what you do. So, Audrey, you represent Sanofi France, and so this is the industry, the pharmaceutical industry, which is part of this debate, and you from the industrial sector, prevention, health, rehabilitation. We talk a lot about therapeutic solutions today. Very concretely, how do you address this issue? Well, very positively, first of all. We all have heard yesterday with the different ministers' words, there's good news. I am optimistic by nature. Once again, I find it's really great when you have good news. Thank you for sharing us with this yesterday. And so when we talk about different industrial actors, we say, curative treatment, of course, this is obvious, but also we are involved in prevention. We have a group like Sanofi, leaders in vaccination. Prevention is really our daily work, and innovation also is important for Sanofi. It's not just vaccinations from the past, but also innovation. Broncholy also has this short-term impact as well. We were hearing about this special HPV vaccination. We'll have these later impacts, but also these infectious diseases. We have positive impacts short-term for the system and also for the families. And here we are very much involved, once again, for the bronchiolitis. And when we go into, and I would like to take the example of the flu, where we have a coverage of the vaccination, which is about for 65 age, which is lower than the WHO. And so to have this societal benefit, we really need to improve in this. We're at 55% only. We still have 20 points to gain. So if I look here in this room, everyone here can really it can be very win-win if we have better coverage for vaccination. We are here to produce medication, but also vaccinations are important for prevention. And don't forget the flu. 60,000 people are in the emergency wards every winter. So we have to raise this question. And this is not just for people that are older than 65, but we don't want to saturate our emergency wards in France. And so 15,000 admissions in the hospital over 65 years of age. So what can we do more? And so when we have different innovative solutions for specific groups, for example, we have the auto dosage for the different cardiovascular, and so this is less known for the myocardial infarctus. We don't talk enough about this. We have a lot of awareness that needs to be really increased about this. Some countries are more advanced. There are specific recommendations that we need to really adapt. So collectively, this is something we need to do better. When we have therapeutic specific innovations, we have to really bring them to the right patient at the right time. I think we collectively can really make more efforts. Thank you very much. So the minister was talking about prevention, and it's really a priority in public policies. The CNAM is already doing things in that area. Sophie was talking about financing. We'll talk about financing for this roundtable. Marguerite? Tell us, all right, what does CNAM do? Because it's known, we hear a lot about this Prado, etc., etc. What does CNAM do today, the National Health Insurance Fund in France, for prevention and for the pathways as well? We'll be seeing later how you can favor coordination of professionals, organization of pathways. But first of all, concerning prevention, I would like to hear your voice. Well, prevention, I can talk about for hours, especially for the health insurance fund, which we have set up screening for cancer, etc., but also concerning pathways, to put it in connection with our topic, to tell you that when the health professionals, health authorities would set up the pathways for patients that have chronic illness, when you set up pathways to identify the different areas of rupture for the pathways, you have to come up with solutions which are preventive. For example, you have first challenge here, which is screening and early detection and diagnosis, early diagnosis, when the main chronic pathologies, in fact, we've done some studies, we've looked at this, we examined this. So last year, in fact, we showed two things. First of all, the French Cardiology Society, when they have hospitalizations that for severe cases for cardiac issues, in 60% of the cases, only 60% of patients know that they have cardiac insufficiency. And so when people have type 2 diabetes, they are diagnosed, and they're in 30% of the cases, it starts when they're at level 3 of the illness. So you can see you have 4 million. All right, level 3 is a higher level because you're already at level 2. You have the 6 million. So the immunotherapy should be done before that. So all this is just to say that we do have our first challenge, which is early screening and diagnosis. We have this health insurance campaign, maybe you remember, which really said, if your heart tells you something, we had this advertisement campaign. If you're tired, if you have edemas, if your heart is telling you something. And so we want to really ensure that the professionals and also the insurance agencies can have these elements to have early detection. It's a little bit, when you hear this, radiology can be stressful, but says the moderator. But it's very important. There's little things that can be done that will enable us. There are different alert signs. And so when you have these alert signs, then you say, you need to see your practitioner, and then they will say, yes, this is alert, we're going to check it out further, or it's not necessary to check it out. So you have then diagnoses. So if a patient who has a cardiac insufficiency has to be stabilized by hospitalization, and then the main recommendation for this patient is really his different lifestyle. And so there are different 4 kinds to also diets and also physical activities is an important element, and also to do their treatment and to weigh themselves every day. And what we're developing for the telesurveillance and artificial intelligence, this is the fact for these patients that have severe insufficient cardiac issues, they should have this weight scale that they can be measured, so they can have these alerts, so they have, because they have different heart efficiency that is becoming more severe, so then they have these alerts. So this is important to say that so in the different this is normal because by definition, okay, the more complicated ones where you have a need for multidisciplinary, when you talk about prevention, and we have coordination, which is very important. There is a population where we talk about less, these are children. I talk a little bit of words because we have 15% of the children that are born with a development problem, a neurological one, 1%, and autism, 5%, PDH, you have different disorders, sensorial disorder, cognitive disorders. And already we see this pathway. It's very complex for people that are aged. They have different pathologies in their health pathway. So also the autistic children and their parents who has an autistic child, they have to really be very, very alert because the diagnosis intervenes at 6, 7 years of age. But the first signs which should be alerted, they come at 9 months. And so we can do much better because there is healthcare treatment that is not reimbursed by the health insurance because you have the health care, but you also have the societal take care. You have the schooling issues. This is the definition of a very complex pathway for children. So we at the health insurance, and I was talking about this because we have this all the different orthophonists, and they have DERVELOY. We have a very early detection screening at the nursery schools for different language delays, different communication disorders for young children, and the health insurance is in connection with the different professions just recently, and this enables a major impact for the pathway of these children. Now, I'm going to say about these subjects, and especially in France, we have the different societal issues in the planet and different levels of severity. How can all the different health actors, different establishments, how can they act together? You have
au fond, il y a un vrai sujet d'alignement de planète pour que ça fonctionne.
So make it function, so we can go to this level. So yes, can you? I will continue. This will be a subject for debate. Stéphane, Unique, you represent VIB, which is a major mutualist group in France, the number one concerning its fees, tariffs. So basically, my question: you do a lot concerning these subjects because you have a lot of different health, social evaluations you do. When you hear Marguerite CAZENEUVE talk about prevention, don't you want to do the same thing? Why don't you work together? There are lots of things you could do together, right? Well, you're going to, at the beginning of the morning, you want to really get us going and or even upset us a little bit. Why don't you work together? We work all the time together. We're complementary so that we make solvent all the different reimbursements for health insurance. We have this health progress. We have these mutualist organizations that have an important role to play. We have extraordinary progress. I'm thinking of the auditory healthcare. We also had in 2009 61% based on this reform. We went to 30% in 2019 because we had investments of the complementary mutualist health insurance. The complementary between health insurance and the mutuals of the complementary health insurance is really a reality today. I do think the force of our French model is this complementary model, which is very important. I think, well, can we do more? I'm convinced. Should we give more health data to the complementary health insurance? I believe we should do this. We'll be talking about this. They're also, I think that they can also be a risk management actor. And also, it's not just with health insurance, but with all the different actors together, we can produce more concerning the pathway of health. You're talking about prevention. Yes, well, what is very specific, we could never replace health insurance. Now, concerning, it's a universal approach. It needs to be addressing everyone. Our approach, which is really unique because we're in this approach which corresponds to the community of our insured. And this is, we talk about prevention and based on the given area, their territories. We talk about Tarbes region with this NMT, which has supported these personnel which are in nursery schools, which are confronted with different professional risks that were very high. We supported them for 2 years so that we could ensure that the risk, professional risk, would be reduced. So these persons that were supported, that produced a very important element for the insurance issues in the collectivity. They had 28 sick leaves per year in the school. Thanks to the support which was done by the complementary health insurance, we went to 5 sick leaves per year. So it was reduced to that. So €1 invested for the collectivity is a return on investment for the collectivity of more than €3. So these different actions we do are very targeted actions. We can never have a rollout as important as the health insurance does. However, I do believe that we can target better different problem areas of health and fragilities. We reimburse 850,000 cases. 24% of these consultations are less than 10 years of age. There's a subject. So there's complementary things we can do, of course. If it was proposed that we had more targeted healthcare and prevention, I would put on the table this so we can have contracts with the government because the different priorities that we should choose need to correspond to the health public policy. I go further with Margaret. We need to sign a contract with health insurance so that we do not reinvent the wheel, what the obligatory health insurance does. Now, the fact of having different actions which are done by the complementary, the mutual health insurance, the investment from the mutualist actors and to contractualize that, I believe that is very important for prevention because the state cannot do a revolution for prevention. Another element is that we are not simply, we have to think of solvency, and we're not just targeting prevention. We also are a health actor in a holistic approach. Now, I would like to say For Deauville, we have 50,000 and 30,000 are involved in support. So this is a subject which is very important. We invest for the health offer, and proximity is important for us. 60 million euros investment we have for the Loire area. We have 3 different departments for proximity. We didn't do this alone. We did this with the collectivities. We did with the different doctors present. Now, for the different wards that were open, early on, we had 16 million practitioners. We allowed them to be part of this coordinated health program. We also have to clear the way. We created this Logement Santé label. It's not in the health insurance. I don't forget the person who lives today in the street. He has 46 years of life expectancy. So housing is a decisive factor in the healthcare system. We created this housing label. We have 40 different criteria for the construction of a housing facility. So, for all of this program, the health is the red thread that goes through all this. We have to be in capacity to be constructing housing, which is really useful for the health of tomorrow. And in fact, the last element, and I think this is a real challenge, is concerning the social economic research. We're lagging behind, and all this around the table will be reviewing the way we can imagine the different social economical risks related to health for the future. Yes, we'll be talking more about this related to industry. So we've gone around the round table. Now, I would like to go back to Virginie. You represent this major group in really high, in one of the top ones in size, so the IMA group. Now, the assistance profession is very particular. You have been able to help someone in Australia. You have doctors that have logistic management skills. So we can ask this question: why do you not mutualize this know-how, which is a logistic one, and also medical competence, so that you can support the different actors around the table in setting up different pathways? This is your job, basically. Yes, clearly it is our job, but I say we do use already. And I can give you some numbers of examples, different examples, when we should, in introductory word, explain that we're not a mutual. We were created 40 years ago by the major economic, social actors, solidarity actors, who had a project, a political common project, which is solidarity faced with the risk of life and accidents. So we already had this pathway and support. And in this framework today, we support already potentially 45 million beneficiaries in all these different areas of mobility, health, service to different people, home care. And so we help a person every 7 seconds. And so we have a network, 55,000 service providers that set up specifications with different quality obligations. Yes, we were talking about evaluation. We do evaluations of this quality. So quality assurance is very important to make sure things are functioning smoothly and to see adapt if we need to. Also, we have staff who have a mandate, a mission. This is very important for the pathway. Our staff are there to listen, to reassure, to orientate persons, and this within this health pathway. And this is an important link in the chain. And this is something that was missing before. And this is why we can have an important role to play. We set up different tools to do all this at the size of France. This requires to have tools. And we do also have set up within our group a platform which is multidisciplinary, medical, social, which is composed of doctors, nurses, different therapists, and all these different actors where we have great needs. This is the supporting of for aged persons, prevention, chronic illness care is important that we work on. We also work with the different our clients concerning everything which is pre- and post-hospitalization. This enables us to support our patient at crucial moments when often they are alone. And we do see that there are lots of things that are set up in our country. And at one point, the patient is at one time or the other, he's alone. So we are an assembler of solutions, and we help this way the patients. And for this, we already have examples within the framework of the COVID crisis. We were able to help CNAM, DGS. We furnish different respiratory devices. We work today in this Cohesion 112. We have the repatriation, health repatriation, evacuations for everything which is for the crisis cell of the DGS. We also have other offers. We adapt to the needs. As Sophie was saying, we are working today on the Article 51, intersessional article. And everything that I've heard today, there is a missing link in the chain, which is the collector of solutions, a facilitator. And I do think that we, with our competence, everything that we've been able to develop, our DNA also of our solidarity in our sport is where we can be the agile resource, which responds to all these needs. Thank you very much. We're going to be talking about all this because I've identified your different, from what you said, different themes. You have the use, optimization of health treatment, and I will be asking Audrey about this. And Sophie was talking about financing. We'll talk more about that because these are very important. We have Article 51, which really will bring up that subject. So yesterday we were talking about the reaction in the room about this lump sum fee area, and so the way our health system is financed. A question of organization, which also I believe is related to questions of changing and getting out of silos. I'd like to hear your opinions about these topics. And also, we talk about information so that the pathway functions. We need a smooth, fluid pathway. So we'll talk about CNAM. Is it that way? And also, financing is important. So I would like to start maybe with the, well, how should I put this? The technical qualitative area, which is optimization of treatment. With your industrial vision, for you, what does that mean in the optimized pathway to make a treatment more efficient? Audrey, as an industrialist, and I believe that if I look at Sanofi in France, we have a foot in the industry and also a foot in innovation. When we think in terms of pathway, is from A to Z, from the beginning to the end. So you have also we have from ID also to production. In each different link in the chain, we see how can we contribute. When I take this example, the different RNA messaging, so it's really good to have innovation in the labs, but if we cannot produce very quickly, if we can't do more agile production and decarbonate it, because that also is a subject on the table today, we'll have problems. So typically we invest in the Lyon area so that we have our special footing and we have our tool for the UDF. There'll be 2 plants there. We have a modular, more agile plant so we can respond to different pandemics of tomorrow, and that we will have the highest ecological environmental standards. So we as an industrial, we have to anticipate the pandemics of the future so that we can do prevention differently. And this is not something that can be done in 3 months. So what we decided a few years ago, and this will be published soon in 2025, we want to anticipate, we want to invest massively for the industrial tool area. Also, all the different links in the chain are important. We're talking about training. I'm not going to go back about this. We do have experts in these areas. So how can we work all together in the area, for example, training of health professionals, but also different campaigns, awareness campaigns. So we were talking about the flu campaigns, but also meningitis. We have equity also. We have to have everyone have access to information. So it's important for us to really make sure that this information is targeted targeted for everyone. It's not always just the same ones who have the information. We have the people that need it the most that have this information. So we have these campaigns. Industrial is also something where in the major groups we can really have a major impact. We have resources in financial ones, but we also are in this ecosystem. We can have an impact there. We're talking about how can we reduce the diagnostic areas and go quicker to treatment. How can we be quicker? We have a Fourceur partner in this organization. We can accelerate startups in the health area. We also, in these, will be launching the screening access care. And this program, we have a platform for the practitioners, and we know that the rare diseases are not very well known, less patients, so this is where we have real problems for access to information. And this is where the very specific symptoms of these rare diseases. So the practitioners, thanks to this platform, there's a questionnaire, they will be able to get quicker a diagnostic recommendation, but also test recommendations. They can also have access to different reference centers. So quicker, these patients, these are more often children, they can have access to these reference centers. So this is a tool at the level of technology that we as industrials, we have to accelerate. We have to make it available to as many people as possible, as quickly as possible. There are lots of other examples, but it's important really to talk about all these different links in the chain. We talk about barriers. We have to really eliminate these barriers as quickly as possible. Now we're going to be talking about organization of financing, but this all goes together. We're not going to do the different conventional negotiations right now, but still, let's 51, this Article 51. Okay, I'm here just to ask questions. Just to moderate. This Article 51 in your context. Tell us, explain. What would you like to do with this, and how can we go and about different chronic pathologies and have an optimized pathway, and how can this be compatible with another part of the medical field, which is probably, how do you handle these kinds of questions? I think, first of all, we have the lawmakers that will be pronouncing concerning this 51 article and the different modalities and its generalization. So what is the 51 article? This is the fact that we have lots of initiatives throughout the whole country. That they haven't waited to have the ministerial decrees, etc. So they already have come up with solutions that function in their region, and they have also been financed with these regional monies, and so it was fantastic. Things are functioning very well. So now it gets really difficult when you'll be going up to a higher level, because then you have to have a data system, etc. So 51 article is related to that. You have your project. It's a fantastic project. And because it's not within the framework, we're going to give you a global total financing, so you can start very quickly without having to ask this question, how can I finance, etc., etc. So that's its first Article 51, just simplification in funding. And so you have this lump sum fee. And so the challenge here is this Article 51 that have been correctly evaluated. That's important. And during the evaluation, during the experimentation, we will be able to look at how we can set up the right articulation between and coordination between the different actors, so that we can have going as quickly as possible to a higher level. That's what Article 51 is all about. And within this Article 51, we'll be setting up a different lump sum fees with different new way of funding, because we want to transmit this message, convey this message that we see in the healthcare system. To go quickly, you have to use what exists. We can recreate new pathways, etc. But no, we want to use what exists. So the health insurance is a really big machinery, and so we have a certain number of things that are working. We want to, first of all, use what works. We're not going to be reinventing the wheel, so we do this lump sum fee, and we also are supported by what exists already. And so we talk a lot about quality pathways and these theoretical exceptions, we can be constructing cathedrals, but we at health insurance, what we say, okay, a fantastic pathway of patients, how it should go in a utopian world, but the real life of the different pathways in the region is the practitioners. They have a patient who's not doing well, he calls the cardiologist, he can't find the cardiologist, then he spent 1 or 2 weeks trying to make an appointment, he can't do the appointment, the patient goes to the emergency room again. So going beyond this super fantastic top-level pathway, but we get down to the level, which is really the availability of healthcare actors. And so 06 is where you have this telephone number that a friend that can take your patient, but it works like that. So this is how this coordination modality, which is really almost 100% of the coordination, has a very stressful issue, because I have different doctors in Saint-Denis. They say it's very stressful when we have patients. We know that they have a severe case. We can't actually get them admitted to a hospital. It's very stressful for the health actors. And so it's a lack of an opportunity for the patient. Also, the more you are far away from the health facilities, less you benefit from the right context to meet the right person. So something which is at the level 0 coordination is called the digital en santé. We can criticize it, but with this digital health tool, we have done a lot in this area. We are really increasing our quality. We will be all the different professional healthcare software systems will be operable, excuse me. And so you have the different healthcare, you have biology, you have the pharmacies, all these different actors, imaging. So this is the first wave, and then we will launch all the other professions for the second wave. So you different problems. I'm not saying things are perfect, but really the result we hope to have is where we have interoperable dose documentation on digital. We have and also the warehouse data storage facilities will have an important role to play. So we do see it should be a comprehensive system. How can we ensure it's a comprehensive system? We have different points, different elements. The main principle of healthcare is to make all the different, the software publishers have to be able to have an interoperable system. We told the editors, if you have an interoperable system, we give you a tool, we give you a label, we will validate that, and this is how we can go quickly. So we have the most automatic inputting of data for health professionals. So all the documents are sent to the patient's documentation, because they are the owners of this, and they should have this data, and so they should be able to have the patients need this information. So this is very important. Yes, and the fact of not having any redundancy of treatments, what we said yesterday concerning the relevance of redoing exams, all of this participates in these long, complex pathways, sometimes that really end up in a bad way. So we all want to be equipped in a very good way. So professionals can consult the different documentations. They can also have a secured messaging system. We've really advanced quite well in this area. How do the different actors that are around the table, how can they help you? Because data is very central, but also all the different professionals that are acting for the medical social actors, how can they all work together? And now this would be locally, you have the different health establishments that are involved in this. Now, so that our partners are around the table, can you express your opinion? How can we help the system to really go to a higher level? That's really where the the challenge is. What do you think, Sophie, concerning these different aspects of cancer issues or others? You're talking about lump sums for certain pathways. We're talking about the preparation of lump sums, for example, chemotherapy. This is a subject where we could progress. How can we organize concretely so we can roll out and optimize our pathways? Well, yes, financing is important because you need to have incentives that are created for professionals to be working together differently. Me personally, this is one of the dispositions that I found already for this special bill for the financing of Social Security. This is something that makes me think of that. But you have to go further and quicker. And I do think I will give you an example now. Data is important. So we had a special health home care program. So we worked on labelizing the different liberal professional nurses because there's a strong demand for them. They need to have updated information concerning therapeutic innovations. You have to support them. They have to share their practices. When we open up subjects which are concerning their different pathways, we have training is important, developing expertise of all the different professional actors, and you really have to have a real strategy in this area. And also, what is fantastic is that professionals have lots of projects. For example, we, with CNAM, we have a chemotherapy in the different day hospitals for the cancer struggles. We have a 5% increase every year. We have to find solutions which are also how we can enable, thanks to therapeutic innovations, that will also enable us to have a better quality of life, different transportation savings as well. And we have this special way so we can transfer different chemotherapy treatments at home. So that means we need to support, and this means change. So unfortunately, we're almost to conclude. We could be talking about this the whole morning. It's passionate. I would like to tell me, and we'll go around the table, to optimize the pathway. Everybody wants to do prevention, care, rehabilitation, etc. I would like to ask each one of you, what for you is the main obstacle today to really scale up? We're not going to start with you. I think you have a really good idea about this, Audrey, but I'm not going to start with you. Well, you tell me as an industrialist. Well, yes, it's as we work, how we act with the actors. What we do, Sanofi, in fact, it's very important to innovate. How we can, what is the added value of this innovation in terms of prevention? We can't do this alone. How can we recognize and just the right price and the right timing when we talk about epidemics is now. And I do think of meningitis. I think of that when we have, if we have the mutations and we put the same timing, how can we be more agile? How can we work together that way? Because the industrial time and the AD is not the same time. So this was very politically correct. It has to go quicker, yes. Stéphane, well, just in one word. I agree. I agree with Audrey. That's what I wanted just to say. A second word?
Non, mais ce que souligne Audrey, je trouve que c'est essentiel. En fait, notre pays est en train de...
So we have an issue here, which is the culture of the law. Let's go back to the culture of contract. Everybody around this table, we can take up commitments. That's good. We have done the work to have a significant size of the industrial point of view, and also as actors, complementary interests have done the structuring of groups which are a significant size. They can also add a contribution, and they're very, very useful to handle these transformations. What Audrey has stressed, I really agree with you. Audrey? Okay, I just have 1 minute, so another element is that we have to really be ambitious and see far. We have not always had answers which were very structuring based on the aging population challenges. So we have social economic issues. I've been obsessed by this issue since I was very young. We're not prepared for that. Another element, which is something that's very important to me personally, I would really desire that we take care of our establishments, our staff, which are in these non-profit hospitals. And so I would like to ensure that the financing which is on an equal footing. So you have advocacy for this? No, because of respect for our families and for our professionals who work as hard in the public sector as in the private sector. But what about the obstacles that you see, Virginie, and how can you contribute to scale up? Yes, as we're saying, we need an actor of fluidity, and we have the capacity of agility, of understanding, and to set up solutions which, of course, are in the healthcare pathway to help the healthcare staff, because really, it takes a lot of time, and we need to get them all involved. Also, take care of the patient, because I think that is really important to ensure that they follow their medical protocol, but also their mental health is important. It's very important. So I think the patient often is alone. As the doctor who cannot find appointments, we also can be there to support, to adapt to the patient's needs, and also be a source when there's deficiencies, because we avoid redundancy in consultations and people that abandon their healthcare pathway. Well, I think this is really a plus that we can really contribute in that for those kinds of issues. Sophie, we've already heard a lot, but just so that Marguerite has time to do the summary. So priority for me is to develop a partner-patient model. It's important that the patients can ensure that they're present throughout the whole pathway, from the definition to the evaluation. And today, it's not equitable. So you have either if we're in a reference health center or whatever, but it's hard to have these. We need those that can help the professionals to define the pathways, because otherwise we need to have, for example, different kinds of pathways. You have different prevention for someone with a high cancer risk, and this is a national issue. And I think we can go quickly, and we can prevent the severe cases, and we can be more relevant. Margaret, I wanted you to do the summary, because as a universal financer, you, in fact, have a mandate, and you assume it completely to integrate all of this and to give really the orientation. Your subject for you to really scale up is what? We've spoken a lot about R&D and digital tools, and so we talk about this technology is really key. But what we've just heard yesterday at France, that the problem of the adherence to the different pathways of the patients is they need more contact, human contact, to adhere to their pathways, because they have so these patients often don't have anyone to speak to, and so we can enable the doctors to collaborate with nurses, differently healthcare aides, and also we have a good geographical pharmacy coverage, so we can have contact with the patients, we can explain their disease, etc. I do think that way we at the health insurance, the different health authorities, regulators, etc. All of these, we have a technocratic approach. Now we have to put human contact back there, so that the patients don't feel they're alone. They have someone they can speak to. I think this is a patient that it will change quickly. We don't have to put up really complicated things. This was the conclusion. Thank you very much.